the culture, death rituals, and grief that, and just focus it on a clinician's experience in a time of COVID. So just as a disclaimer, this is not a comprehensive review of culture and rituals, and as you've already alluded to, this is a really personal space, Andrew, and it differs greatly within and across cultures. And South Africa is such a melting pot of culture. So I think this is a really good place to start around creating a palliative care program that is individual, and we need to adapt to the needs of our patients. So the way I've chosen to sort of start this conversation is just sort of unpacking each of these three things that appeared in the title of this, which is culture, death rituals, and grief. And then just sort of, I've put together just a few points that then maybe we can springboard off and discuss a bit further. And again, this is not comprehensive, so please, give me a little bit of leeway here. So I thought when I was approaching culture, I wondered what was the most important part of culture to address. And in this context of a clinician's approach, I thought it would be interesting to address medical culture around death and the medical culture around COVID, and then finally how that meets with the patient's and family's experience of death and bereavement around COVID. So to start off around medical culture, when I was sort of unpacking it in my head, I always have this impression of a culture of denial around death, and sort of these inappropriate behaviors and actions that result, and it results with these in these very difficult ethical decisions, and sometimes trivialization around death. I'm sorry, that's my phone. Let me switch that off. Hi everyone. These inappropriate behaviors and actions that come from the denialism around death makes us really it's this complex relationship with death that clinicians have, and what we do in the name of a heartbeat over everything is just incredible. And I encourage everyone to look back at Dr. Drent's lecture when talking about this. And I thought that the question that is at the heart here is what is truly a preventable death? What are we actually striving for? And what is a realistic hope of recovery within the resources that we have available? And that leads me to the sort of the second point of medical culture around COVID, and that's that binary understanding of COVID. We've got this big population of clinicians who catastrophize the COVID environment, and then this big population that trivializes it completely, and there's very little middle ground around where we actually meet. And I think it must be really complex for patients when they meet this culture around this medical denialism around death and the medical culture around COVID. It must be really hard for patients to start understanding how to approach it, and bearing in mind this that there's this huge power dynamic that's at play, and that comes from knowledge around COVID, around medical problems, and then how we deal with them. And in particular, what strikes me as important is that all the power resides within the medical practitioner, because all the principles of ethics are sort of rooted in knowledge. And in order for us to engage with these topics of autonomy, of beneficence, of non-maleficence, of justice, you need knowledge and background in order to apply them appropriately. So it must be really hard for patients to actually engage with that. So what I'd like to point out here is that medical practitioners need to become comfortable with the topic of death and dying, especially in COVID, where we understand that there is a fair amount of non-preventable death. And I think this is a very uncomfortable space for clinicians, where COVID is limiting our power that we're so used to having in this space. So we have to become comfortable with uncertainty. And I'd like to refer all of you onto a paper which I thought was just fantastic by Frank Brennan, of Australia, where he, so that's my cat, very, very disruptive in the household. It's a wonderful paper about poetry and palliative care, and how these two disciplines have such an overlap, and becoming comfortable with uncertainty, becoming comfortable in that space, how important that is to managing death and dying. So yeah, that was published in Progress in Palliative Care in 2019, and it's a fabulous article if anybody is interested. The last thing that Dr. Brennan mentions in here is he posits this wonderful curiosity as a central part of allowing the palliative care practitioner to perform their job. So that really brings us really nicely to the next section, which is going to be on death rituals. So before I finish off here, I just want to ask the question, where's our power in this space? And for me, I think that's recognizing what is truly a preventable death and what are we achieving. And I hear this question of people, or this observation that people are saying, I'm playing God as a doctor. I'm making decisions around who's going to die, who's going to live. But in my opinion, it's not the right question. There's a lot of power that we do have in this space, and we do have great limitations. And you can't hold yourself responsible for taking decisions in an environment that is imperfect. Before I finish off here, I'd like to relay a personal anecdote just around this topic of culture. And I'm finding it very interesting around the culture of how medical practitioners are handled in the social environment now. I don't know if anybody else is feeling greatly stigmatized, but there's quite a lot of reluctance to visit a medical practitioner in their rooms because of COVID. And what I found very interesting is I was walking in a shopping center, and one of my patients, a well-known patient, didn't even recognize me. And I thought, oh, this is very strange. He would always have stopped. And I realized it's because we're wearing masks, and obviously I take off my glasses immediately because they fog up, and people aren't recognizing each other. And so much communication happens on that level. And I think, yeah, we're missing out on a lot. So that brings me to death rituals. And I thought there were 4 things that I'd like to spring off here, and we can open the discussion with. To start off with is just some medical death rituals, again coming from the clinician's perspective of death and dying, and then religious and cultural rituals, and then finally the interface of those two. And I really wanted to unpack a particular part of rituals which I encountered recently at a hospice, which I was trying to decide what does this ritual mean? Where do I put it? It was a wife who wanted to wash her partner's body, and I thought, gosh, this is a really complex thing, and I would maybe put this to like a physicality, sexuality part of dying. And I think a lot of us are ignoring a lot of those complex things around what do we need when we die. Anyway, so back to medical death rituals, I was sort of unpacking. I thought, I wonder what are those rituals that I go through, and I thought, certification of death, sure. The nursing staff certainly go through preparation of bodies, wrapping of the bodies, those practical aspects around death, and then bureaucracy and documentation. And that's sort of like getting that final death certificate, issuing the Schedule B so that they can issue a cremation order, get the patient cremated. And I thought these are very interesting things as far as a clinician's ritual is around a person's death. And I think we all, that can be really trivialized, and I'm not sure that we all engage with it as much as we should. I probably write 2 or 3 death certificates a day, and you don't really think about how what this death certificate means for the family who's going through this whole thing. And just before this time, when I was about to sit down here, I had a call from a patient's family. They couldn't find the death certificate. It's lost because of all of the problems. They're closing the departments because of a COVID scare. They need to deep clean. There's all these delays, and it's super stressful for those family members. The second point there I wanted to mention was these super personal religious and cultural rituals that that people go through, and I don't want to labor that point of specifics, and maybe we'll get to know specifics when people share their own experiences. But yeah, these are super personal things, and interestingly, I find that they're probably the greatest source of conflict within families around death and dying. You know, that come to mind as a brief example: a Jewish person wanting to be cremated, a Kenyan person wanting cremation for reasons, but their family want to bury them. You know, so lots of interesting things. And then, yeah, I don't know if anybody has some experience in the COVID environment. Interestingly, around the case that I put forward earlier around this wife wanting to wash her wife's body. If anybody has any experience in the COVID environment, because this case was not a COVID death, and it occurred to me that it might look very different if this was a COVID death, and what and how we enable for connection and touch in the COVID environment. And then finally, around the death rituals, is in this time of COVID, we're taking this already traumatic time in a outside of COVID time, and we're adding all of these dynamics, which have very little to do with death and dying. Things like the bureaucracy of the death process, these slow-moving processes that are already problematic, closures of department, management of remains. I mean, I get a lot of, I've had quite a lot of discussions with nursing staff where they don't quite know how to wrap the body. You know, now at neck care, they're saying you must wrap twice, and here in the government guidelines it says something different. So there's all these complex things that are now coming into our clinical space, a very fragile clinical space, where in order for us to feel comfortable, we need to have confidence to practice these things, and we just don't really know. And that comes right back to Dr. Brennan's point around becoming uncomfortable with uncertainty, and I think that's so true of this time. Finally, the third big topic in this talk was around grief and bereavement, and I think I don't want to unpack this too much because Dr. Drent's presentation was so fantastic and comprehensive. I again encourage all of you to go and have a look at that if you haven't seen it already. You know, these grief responses, these emotional, behavioral, cognitive, physical, spiritual responses that happen in the context of death and dying are complex for the family, and something that Margie mentioned before we started was, remember, the clinician's experience of grief. And interestingly, again, coming back to that point of what is actually preventable, what is that we can take responsibility for. I think there's a lot of inappropriate clinician guilt, inappropriate responses to these scenarios, which result in very complex emotional states for the clinician. And Dr. Drent dealt well with some of the practical points of dealing with some of these complex issues. So I think as I'm wrapping up here, and then we can sort of open up to the floor to discuss some of these issues in context with some examples, hopefully. I don't really want people moving into a space that they're uncomfortable, so that's particularly around grief counseling and management of these scenarios. We're this large community of people with lots of very different skill sets. you don't really want me adjusting your ventilator settings, but maybe call me for grief stuff, for dying stuff. You don't want me dealing with well, please don't have me do any surgical procedure. But everyone has their strengths, and yeah, I feel like we have this wonderful community, and it is a bit like speaking to the converted here, unfortunately, because we're all in the same sort of field. But don't step beyond where you're comfortable. I think this is an opportunity for us to grow our skills. But it doesn't mean that you have to practice in a place where you're uncomfortable. So in closing, I asked myself, where's our power in this scenario? And I thought there were four big points, which is we are powerful because we can identify people who are at risk in this complex scenario of culture, of rituals, of grief. We can recognize where people are in danger. We can recognize where complex grief and bereavement is going to happen. And in those scenarios, we can refer, or if we are comfortable ourselves dealing with it, we can deal with it. 2, we can recognize our limitations and draw our own boundaries. And that's particularly around maintaining your own person, that you can actually help people. And unfortunately, realistically, not everyone is going to get perfect care, but we can give good care to a lot of people. 3, early referral to us people, palliative care people. I know, again, speaking to the converted, but yeah, I think there is this this interventional mindset that people want to just save that heartbeat beyond whatever, and that's not really the needs of many persons. And then finally, delegate. What I found in closing is this wonderful quote that Dr. Dren said, is that grief is always complicated. And I thought I'd add my own little thing here, which is that, but not all grief is complicated grief. And grief actually has a natural history, and most people will deal with their grief well. This isn't a wildly complicated scenario. We need to identify those at risk. And we've got all of this information and data at our fingertips to address these issues. Yeah, so that's where I'm closing. Sure. Well, anyway, so I'd like to open up to some discussion around specific scenarios where culture is influencing our experience of the dying process, particularly around COVID. I think because it would be nice to remain focused on a clinician perspective, because I think that's where we're approaching it from. So yeah, I wonder if anybody has something to share or can add.
Well, I think first of all, thank you, Craig, for the sort of springboard to the conversation. And as you said, and quite rightly so, it is quite complex. But I think that the one thing that everyone needs to acknowledge, and I think probably palliative care specialists are particularly good at it, is the level of empathy that's required. And I think that's the one thing that needs to be considered. And there's many hard conversations that are had in the scope of the field. I think it's also interesting to understand at what point the conversation about potential death rituals might come into play, if at all. Also, if we talk about the complexity of perhaps working with junior doctors who might have lack of experience of dealing with it, it also becomes quite a complex space for, I suppose, for doctors who are team leaders effectively.
Yeah, I think experience is so important, as you say, and this comes down to personnel management. I know we've mentioned it before. What resources do we have to support persons without the experience in death and dying, and especially where we are seeing a lot more, or people are seeing a lot more death than they would otherwise see. how are we supporting our colleagues who don't have the same experience, as I would need support in a field where I don't have that experience. You don't want to be left floundering.
Janet's hand's popped up. Hi, Janet.
Hello, Andrew. Thank you, Craig, for a very thoughtful presentation. The issue of how people deal with it for us as the hospice, the question that comes up for me is staff attending funerals, and it seems to vary from person to person, but some of the nurses feel that it's very helpful for them to go to a funeral. Other times there's pressure from the patients' families to attend a funeral and they don't feel so comfortable, but they do it. And that's all going to change now because funerals are so dangerous for people. They seem to be the hotspots where people get infected very easily. So that's a whole issue. The other thing that we always do is write a condolence letter, which is signed by me as a doctor and the nurse and social worker to the family. And I've read research about that, and apparently it's quite a helpful thing for families to get that letter, and included in the letter as an offer for bereavement support if they should want it. So I think those are the thoughts on that. And then the other really sort of urgent thing for me is how senior medical students who are in the clinical years are being supported at present. I've got a niece who's at Wits in 6th year, and she's got classmates who are just falling apart around her because the clinicians are so busy that they don't have time to hold hands and mentor the students. And the students are really, really sort of rudderless and struggling with this huge number of deaths that they're seeing, and also just not being provided with PPE, or all sorts of risky things are going on. So those are sort of issues that have come up for me.
Janet, I think, sorry, I'd really like to chat about the medical students thing, and I'd like to tie it to the medical culture of denialism. I think medical students are very interesting because they're sort of the breach between lay people and medical people, and so there is this I don't know, certainly when I was a medical student, I often felt like I was neither in neither space, and I was expected to be able to be a doctor already before I was a doctor. And yeah, certainly there's I don't know, I felt like there was never really support at medical schools for these things. Although UCT was quite good at supplying sort of debriefing, when you're in the clinical environment, that wasn't the way that things worked. You're sort of treated as a staff medical officer. It's almost like they feel like you should have, or you should be able to be functional as a 5th year student doing ward work. So I think that's a very interesting comment that you made, is how we're going to support our medical students through this time, because they are not doctors and they haven't yet acquired the skills that they need. Margie, I'm sure you have an opinion about that.
Yeah, interestingly, we've just finished a week of training, the 3rd year undergraduates at Stellenbosch University in palliative care. It was all done online, so it was a new experience, but their feedback has often been that, when they show some distress around a patient dying or being seriously ill, the mentors, kind of give the message of man up and get on with it. You can't show emotion in front of a patient, for example. So I think what they I suppose, as with children, you learn in what you see, not what you're told, and I think sometimes the way older doctors do things that it's hard to follow that way if you're young and enthusiastic. So I see the young enthusiastic, I want to care, and this is why I'm doing medicine in the 3rd years, and then for some reason it fades by the time you get to your 6th year.
Yeah, I find this we've a lot of people have been trying to use COVID as a focusing device for acknowledging problems that exist already. I think we see it in the social activism spaces, particularly, in terms of racial inequality and our colonial struggles in the past. I don't think there's any doubt that there's a clear relationship with the spearheading of Cecil John Rhodes, in that space. But yeah, the culture is the culture within medicine. I think the point that I'm trying to make is that there's always been this culture within medicine, and now we're seeing it acutely. I think a lot of people in their formative medical years, I certainly did, you kind of put your head down and just want to get to the other side so that you can be a real human. And yeah, there's very little support in humanity in like fostering human growth within the medical culture. Certainly that interventional, like physician internal medicine, general surgery culture of it's do, and once somebody is deemed dying or dead already, there's very little empathy, or I don't know what the word is that I'm looking for in that space, and it's quite dehumanizing. It puts me in mind of that wonderful quote of, you matter because you are you, and you matter until the end of your life. I feel like this is not fostered in the medical space. And maybe this is our journey, where the social activists are using this as a time to focus on inequality. Maybe it's our journey within medicine to be focusing on medical culture of this sort of anti-humanist approach that we take, this sort of biocentric approach to let's cure this body, rather than let's make this human valuable and comfortable and achieve their goals.
Craig, I see a couple of hands have popped up, so you've sparked a bit of conversation. Linda, if I can ask you to unmute, I see your hand went up.
For this very insightful contribution. I've just been thinking about our whole culture in general, or many cultures in general. In the old days, people died at home, and families sat next to the bed, with the patient, caring for them, with very little support from doctors and limited resources at that time. With the development of medicine, things have become very bio-centered, as you said. And I think children are not reared to accept death as part of life. So we kind of see death as a failure, just like doctors see death as a failure. While in fact, we're all going to die. There's no way we can get through this without dying. So I actually think children should be taught about death at school level. The topic should be discussed. And we should talk about good deaths and bad deaths and what causes death, and really just be comfortable around it and acknowledge the importance of emotion. And then the power dynamics of death will become different, because I've seen families who have not had the time to prepare, that where there's a sudden illness like with COVID or whatever, those conversations were never had. And then it's a real crisis on top of other comorbid emotional and psychiatric problems, which makes it much more complex. So just something to ponder. Thanks.
Linda,
thank you very much.
I'm with you there. And I think maybe if we can just label it is that medicalization of death. There's this impression that death is this medical problem, but it's actually a human problem. You don't have to die in hospice or in hospital. You can actually die at home. So I love that point. Thank you.
And then also Diane Berger, you've got your hand up. Diane. I think you might still be on mute.
Yeah.
There you are.
There, yeah, okay, thank you. I don't mind you seeing me either.
Feel free, feel free.
Now that I've had my hair cut after 4 months. Oops, how do I, oh, there we go. Sorry for the delay. Craig, thank you very, very much for what I might call your vulnerability or your openness in terms of the whole issue around COVID. Having had quite a bit of experience, well, a lot of experience in palliative care, but now being exposed to trying to support families mainly, but wanting to support professional staff who are very reluctant to come forward for that support for many reasons, which we do understand, and it's really sad. But thank you for opening up this conversation, and I hope you don't mind me drifting away from what you said about can we keep this to the clinical domain. But I have found, and in very intimate conversations with some doctors in palliative care who, and my experience, doctors in general, I must be careful, but are very, very proprietary about their patients and reluctant to share the care, as it were, in a palliative care context. So I think that that's one thing that COVID has opened up, is the opportunity for the psychosocial aspect and spiritual aspect of care to really come to the fore. And there were a couple of other things in terms of family support. From my experience on several help and support lines, the fact that there are psychosocial people who are able to make contact with families of patients who have either died, and you say, you know, after this absolute tsunami for clinical people of deaths, and it becomes impersonal for obvious reasons, but that opportunity to just make contact with families and talk about how it was, and give the opportunity of explaining, well, what was your dad or your mom or your relative? What were they like? What happened in their lives? And so on. And people are just so grateful to be able to give their story. They've accepted that, well, the ones I've spoken to, that their relatives were old, they had comorbidities, but gosh, they were people before. And this has been a great experience for me. So I think just to conclude, and thanks for the indulgence, but the opportunity for that extra support, for that psychosocial support, for the bereavement support, that intervention can make such a big difference. And it's very satisfying for us in that role, you know, if we're not particularly clinical people, although we have an interest there. So that's been one advantage. The other advantages of COVID, I have still to discover for myself, because, yeah, it's been horrible.
Well, thank you so much for sharing. I've just been following a little chat that's been happening on the side. And thank you to Christine. You actually prompted something that I read in possibly one of my favorite books by Atul Gawande. In that, he makes mention, our ultimate goal, after all, is not a good death, but a good life. And I must thank Christine. I've asked her just to come in and just also comment on that. Specifically from a cultural point of view, Christine's mentioned that she's found whilst working in Muslim communities, they're often more accepting of death. And I would very much like to unpack that a little bit, because I think that's an interesting point. Because in a further conversation, you talk about the support from family and the relationship they potentially share with grief and bereavement and physically losing someone. So I'd appreciate your sharing. Thank you.
Hi,
Welcome.
Andrew. Thank you.
you.
I've worked in Muslim communities and have found them very, very supportive of each other. And this has really, really helped with them processing their illness and, towards the end of life, really accepting it. And sure, I feel that in other cultures, and we really, really are against, accepting one's illness and then obviously the dying process. But yeah, it's really a community feel in the Muslim communities with their families all together and everyone playing their part, whether it's going to, day clinic to, get medication or feeding or, mobilizing the patient. Everyone has come together to help, which I feel really helps the patient as well towards the end.
And do you think it's potentially also the fact that the death rituals in the Muslim communities are set?
Yes,
it's a set ritual.
Yeah.
It almost takes a lot of pressure off the family. I see Shireen's also nodding there. Hi, Shireen. So I think that might also be part of it potentially.
Yeah, absolutely. I think when we do have these conversations about do they need any spiritual support, they've got all their plans. They know exactly who they're going to contact, and all the burial stuff is organized already. I don't think I've been into a Muslim house where they haven't had these things in place. So yeah, it's kind of comforting sometimes to go into these houses where they have got some of this stuff organized already. Takes the pressure off us starting these conversations.
Katja, one of our PALPRAC members working in Mitchell's Plain in the hospital there, actually took particular mention to say how well the undertakers in the Muslim communities were dealing with specifically COVID cases during this time, and how incredibly efficient and empathetic they were. And so, yeah, just to also extend that, I see Shireen's also nodding. I don't know if you also want to add in, Shireen, of course. Yes. You're going to have to unmute yourself, I'm afraid. Thank you, Christine.
No worries, thanks.
Yeah, thanks, Christine. Look, as a Muslim, I felt I needed to comment, okay? I do agree, Christine, yes, everything is actually quite planned. Upon hearing a death, a family member will automatically start making arrangements. So the people who are directly involved with the death, for example, when my dad died, I just send, you just send out a message, but prior to that, people already are linked with you, and they will take over everything. And the undertakers have everything planned. They will arrive at your home. They will take the person's body, have it, given the ritual bath and wrapped in cloth, etc., and brought back to your home with everything that you possibly need for that, so you don't have to worry about that. Other families will come in and say, look, I'm organizing this meal. Tomorrow, this person will organize the other meal. So the actual family has very little to do in that 3-day mourning period. And that is a very helpful thing. And the comment that was made earlier on about death being something, I can't remember, I think it was Linda who made that comment, is something that should be discussed from early on in life. And that was my experience, because there's a standard prayer one reads, to God we belong and to him is our ultimate return upon the moment you hear of someone's death. And you taught that little prayer from the time you little, okay? And so there is no question about you attending a funeral. So even if it's been a very tragic death, the person's body would come back home, or, properly wrapped. We don't dress the person's body in clothing. It's wrapped in 6 meters of white cloth, and the children are part of the funeral process. It's part of their lives, and so it isn't something, should the child go to the funeral or should they not? And I came across this when I had to work cross-culturally, and there were huge questions around, I'm not going to send the child to the funeral, should I send? And I thought, you know what, that's something that I would never dealt with or had to deal with. Going to a funeral is just the most natural thing in the world. And so that was very interesting. Yeah, so there is a lot of psychosocial support, but COVID has many implications for this, and families are struggling hugely because only 50 people are allowed, as you know, to go to the funeral, and that includes all the admin staff that are involved, the undertakers, etc. And nobody except for very close family members are actually allowed to visit. And people that are living in apartment blocks are finding this really hard because supervisors are not allowing more than 1 or 2 people. So yeah, it has changed a lot in terms of dealing with the rituals, and it's causing a lot of secondary stress and trauma. And we're going to see its implications much, much later. So those are further conversations that are going to have to take place.
Thank you, Shireen. Craig, can I just check in with you? I see you making frantic notes there. I'm sure you've got something to add. Thank you.
What interesting points. Thank you so much, Shireen. And yeah, Hospice Vets, interestingly, is situated right next to a mosque. And what I find very curious is that we see very few Muslim patients. So yeah, I wonder how often because of the accepting nature of death as a part of life and the integration right from an early age, I wonder if that's why as Western medical practitioners with a very structured approach to death and dying, that maybe we are excluded and not involved. And it's interesting that when I have been involved with a case that involves a Muslim family, and again, I think this comes down to individualization of treatment programs and how you apply everything, is there's actually always been a degree of complexity. Either this is a person who is part of a Muslim family or who is converted, or there's complexity in the way that the dynamics play out. And yeah, I liked you made the use of the word, when you practice cross-culturally. I think that it's exactly it. When the medical culture, the sort of Hospice Vets in Houghton, a white privileged culture meets with a very different culture. Often there are sometimes problems, and in fact, my own experience of death in a Muslim environment has actually been pretty negative. There's been a lot of family fighting, a great deal of trauma, and often it's to do with death rights. Like one person wants this and somebody else wants this, and then there's they married a Christian woman, and so now the Christian woman wants this, and so I think that's probably because we don't usually see it, because there is because the community is so self-supporting. But yeah, I do wonder, and I'm so glad you mentioned it as well, Shireen, is that I think COVID is going to change this, and it's going to force together these two environments. We're going to have this very biomedical approach to managing people with COVID, and then suddenly when people do die, it's going to be in quite a biomedical way. They're going to be attached to oxygen. They're going to be receiving morphine for breathlessness control. It's going to be quite a jarring environment to be in. And yeah, in addition, you also mentioned it a little bit. Like I've often thought to myself, we have quite a lot of Jewish patients, but the same is true of Muslim families. Is that there are restrictions in terms of when burial needs to happen, and if we are going to be having delays with documentation and things, I feel like there's going to be a lot of people who feel violated, sort of greatly, you said stress and trauma. I like the word violation for sort of cultural infringements. And yeah, I wonder what you think of that.
Yeah, Craig, that's very interesting. May I talk? I don't want to hog the space.
No, please. I'm
okay.
very interested.
Yeah, Andrew, look, I've just given you an example of a non-complicated way things go. And one of the things death does is definitely, in some instances, puts family feuds aside. And you get on with the death and you get on with the process, okay? And those issues will emerge later. But yes, in cross-religious marriages, there are issues. And those are conversations that actually have to take place well before, early on in life. So that these, and I know I used to feel very uncomfortable, but many would say, like my mother would say, when I die, please don't wait for all the relatives from Joburg, because the idea is you bury as soon as possible, okay? So these are conversations that happen naturally, sometimes over the dinner table, either in, in a casual manner or whatever. The other thing is, yes, violation. We're going to be we're not only going to be dealing with the loss of the person, but we're going to be dealing with the loss of cultural practices and rituals around funerals and burying. And those are the things that we're going to have to, it's the latter, the dealing with the grieving with the loss of the ritual that went with the death. And it's going to just be, those are going to be really difficult to work with. Well after COVID and into COVID, and I think, you know what, the Muslim community, I'm sorry, I might be fired for this, but there has been proportionately larger deaths in the Muslim community in the Gauteng area, for example. And it is also this kind of sort of feeling they have in terms of a sort of immunity from this. But they've been, some of them have been defying rules and regulations, and there've been repeated messages over various WhatsApp groups about learning to respect the laws, the rules, and the regulations. But it's just this intense desire to commit to practices. And there's a lovely saying, it is who are the foolish among the devout? A lovely phrase in one of the books that I read. I can't even remember the title. But there are many foolish people among the devout who seem to be going against rules and regulations in order to establish firmly, their ritual practices. So there's so many aspects to deal with.
I think part of that also, yeah, I think, Shireen, part of that also comes into, our original discussion, which was around, how can culture mediate grief reactions. And I think a lot of that is also goes back to our role to be empathetic. And sorry, Christine, I'm going to give you a chance to talk now. Thank you for coming on. But I think it is to make sure that those conversations are had and that, in advance, should the time arise. Christine, if you'd like to just weigh in as we could sort of come to a close. Thank you.
Yeah, I just want to mention, I recently had a patient's relative phone me frantically, saying like, we need to start doing these advanced directives. I'm concerned about my elderly father. And I think this is quite important during this time of COVID, that we are having these hard conversations with people. What are our advanced directives? Do we want to stay at home? Do we want to go into hospital? And having these hard conversations, especially with the elderly who are at risk, and especially, those with comorbidities and people with cancer, obviously we're keeping them at home, but for this 83-year-old, what is the way forward for him? And definitely, future planning and planning of his death,
Absolutely. And I think irrespective of the cross-cultural differences, it's also to try and acknowledge and and sort of make those happen for their people within certain limitations, I think is quite key. And I just want to reflect back on something that Attila contributed in the chat earlier, and I jotted it down, mentioning I think it is also important to distinguish between avoidable death and unavoidable death. Helping coming to terms with an unavoidable death is sometimes easier. And I think, Craig, maybe this might tee you up for sort of a parting shot or a closing comment. Because I think it is, I think that's what COVID has almost put the magnifying glass on for us, is saying that, you know, a lot of this is, you know, is going to be technically avoidable in traditional medicine, and we're having to deal with the fact that it's not. And I think that's part of the pressure that clinicians and doctors and healthcare workers are dealing with.
Yeah, precisely. Actually, I mean, I had used the word preventable and not preventable, and I think avoidable, unavoidable is actually better. Just because I think once COVID is there, you know, prevention is we're gone. You know, we have to then deal with what you have and the resources that you have available. So yes, I think understanding that difference is crucial to allowing clinicians, particularly dealing with their own feelings around this, recognizing that they have given everything that is feasible to managing a person at the end of their life, and for families who then have to deal with the bereavement thereafter, or at least their grief and bereavement. And I think, yes, certainly maybe an unavoidable death is easier to deal with just from a logical perspective. But, you know, as Dr. Drone said, you know, it's a personal process, and people respond to grief in many different ways. And so in my parting shot, as you referred to, I think, yes, there's we do need to consider that as part of our cultural understanding as medical professionals of what death and dying means. Is everyone is going to die, and there are some avoidable deaths, which hopefully we deal with the thing that we have available at the time. And there's that wonderful old quote, which is, you know, do what you can with what you have available, and when you know better, do better. And I think you know, you have to use that at the base, and just realize that you can't do everything. You can't save everyone. Everyone will die, and there is some there are some deaths which are avoidable. There are some that are unavoidable. So in terms of culture, that's important to change. And then in order to take that further into this whole thing, into this whole topic of culture, death rituals, and grief, is share the that load with professionals who can actually contribute, and something that we didn't really speak about is bringing in non-medical personnel, using what you have available. So I mean, we've been speaking a lot around Islam and other cultures, but you know, there are spiritual leaders that can assist in this way. And yeah, I think you know, we don't have to take everything on ourselves, and that's a very medical culture thing as well. As to, this is mine. I like who said that people are proprietary around their patients. It's very much like that. But you know, this isn't all us. This belongs to us, the family, the patient, and in order for us to deal with this, there is so much available to us. Oh gosh, I've got really off the topic here. Point is, there's things that can be done, and find the right people to deal with them, because you may not be that person.
Yeah. Well, I just in closing, Craig, I know that you're incredibly busy, so thank you very much for your time, spending it today and preparing the thought starters for everyone who contributed. It was a big group that joined us today. And just in closing, I just want to reflect, and I've shared the link on our chat, a beautiful piece that was written around dignity and palliative care in the time of COVID by Raksha, one of our PALPRAC members. And there was a quote that was shared, and I often reflect on it because it's so important. Kindness, humanity, and respect, the core values of medical professionalism, are too often being overlooked in a time-pressured culture of modern healthcare. And I think that, you know, sometimes we almost have to focus on the little things and slow down to do what we need to do. And this is particularly pertinent during COVID. So I think a very, very interesting point. Feel free to also to have a look at that article, very beautiful piece written by Raksha. To all of you that have joined us this afternoon, thank you very, very much for your time. It's always lovely to see all of you. It's a bit of a roll call for us just to check in with everyone. Thank you for the amazing work that you're all doing, and for all of your contributions. Thank you very, very much. Stay safe and have a lovely evening. Thank you, everyone.
Thank you, Andrew.
Thank you.